Good afternoon, everyone. All protocols observed. Let me take this opportunity to thank the University of Dodoma for having invited me to deliver a keynote speech in this very important conference of its kind. Being a believer of universal coverage, I'm very much humbled and privileged to deliver this keynote speech. My name's Ntuli Kapologwe. I'm the Director of Preventive Health Services here at the Ministry of Health. I'm very much delighted to be a keynote speaker in this very interesting conference of its type. And my talk will be on the Tanzania's journey to achieving universal coverage, and I'll be looking at the challenges which we have had and also the opportunities ahead in ensuring that we have health for all. Our Tanzania history as far as the health sector is concerned is quite very rich. It's dated back in 1800, but of notable interest is 1891 when the country established the medical department under the German rule. But during that time, most of the services which were provided to the majority of the population were predominantly traditional medicine. In 1961, Tanzania gained independence, and the founding father of our nation, Mwalimu Julius Kambarage Nyerere, declared three enemies. The first enemy was poverty, the second one was ignorance, and the third one was disease. And actually, it was during this time when the government of Tanzania started to lay down different strategies to fight those three enemies. And in 1962, the founding father of our nation, Mwalimu Julius Kambarage Nyerere, actually commissioned a team of experts to look into the healthcare system and what can be done to make sure that the healthcare system becomes responsive. But of interest, it was in 1967 when we had the Arusha Declaration. Among other things, the declaration was for health for all. And for some historians and some scholars believe that the Arusha Declaration is the foundation of the Alma Ata Declaration, because this happens actually close to or more than 10 years before the Alma Ata. And the Alma Ata Declaration, the slogan was health for all by the year 2000. So Tanzania has been into the journeys and journeys, but all these journeys were geared towards achievement of universal coverage. But in 1990, actually the Ministry of Health established a primary health care program under the Department of Preventive Services. All these actually initiatives were done to make sure that the actually universal coverage is achieved and also bringing services close to the community. So these are some of the key milestones which the Tanzania is going through to arrive where we are today. And looking into universal coverage service coverage index as per year 2021, we have our coverage index of 43, which is not big as compared to some other countries, especially those in the global north. But if you look at what is happening in the continent, you find that majority of countries in the continent are the ones who actually have the universal coverage index between 38 and 50. So even Tanzania is one of those countries in terms of universal coverage index. So what are we supposed to do is for us to be able to have universal coverage like some other countries, which is deep gray, which is more than 71. And to arrive to that, there will be some things must be done, and these doable, and with what we have been able to achieve in the recent years, I believe we shall be able to achieve that milestone. So if someone asks, what is universal coverage? This means that all people have access to the full range of quality health services they need when and where they need them without financial hardship. And as per this definition, there are three keywords: access, quality, and financial hardship. So if one has to achieve universal health coverage, the health services must be accessible, but being accessible is not enough. They must be of good quality, and they should push someone into financial hardship. And the follows the universal health coverage cube, that the universal coverage aims to provide more and better quality services to a greater population in need, while also increasing the level of financial protection. So looking at the cube to your right-hand side, you see the horizontal line is about the population who is covered. Under universal coverage, we are leaving no one behind. So everyone has to be covered. Regardless of their financial capabilities, everyone has to be covered. Looking to the sideline, there is what we call services. Which services to be covered? Everyone must enjoy the full range of services as per need. So that's another key component of universal coverage. Looking into the vertical line is the cost, the proportion of the cost covered. That has to be fair enough for those who have and for those who have not. And that brings us to the Tanzania Health System Organization. Our healthcare system organization assumes pyramid shape. At the base, we have the community, and then we have dispensaries, we have health centers, and district hospitals. And all these four components constitute what we call the primary health care, followed by the regional hospital, zone hospitals, and the national hospital, which actually sits at the apex of the pyramid. So 95% of our healthcare system facilities are in the primary healthcare component. So that means that this is a key or gateway to the healthcare services in Tanzania. So looking into one of the component of universal coverage, which is access. Access to healthcare services is grouped into two main components. First, the health facility based and also the community based access to healthcare. And what is access? Access simply defined as having timely use of personal health services to achieve the best possible health outcomes. And some other people have also redefined it as actually presenting five key domains. That is acceptability, approachability, and also availability, accommodation, affordability, and appropriateness. So these are some of the domains which can also be used to define what is an access. And access should always take into account the whole range of services, from promotive healthcare services, preventive, curative, rehabilitative, and palliative services. And the availability of healthcare facilities should always be from the public and the private sector as well. And looking into the distribution of healthcare facilities in Tanzania, you find that 60% of facilities are owned by public, whereas 40% is owned by private. So for us to achieve what we call the universal coverage, we must embrace the public-private partnership for us to be able to achieve universal coverage. And looking into the quality, there have been a number of definitions in terms of quality, but of interest, I would love to use the Donner-Abedian quality framework or model of 1988, and this has been one of the models which tries to explain what quality is. And it has defined or divided quality into three main components: the structural quality, the processes, the outcome. Under structural, we talk about the means, the staffing level, the equipment, the ambulances, the supplies. The processes is the interaction between the providers and the clients, investigation, examinations, all those procedural things which are provided at the facilities. Whereas the outcome, then this should be the morbidities, the mortalities, the satisfaction, the feedback mechanism which you usually get from the clients who have been attended at our healthcare facilities. But why do we pay much attention of quality as one of the components of universal health coverage? Poor quality causes more than harm, death more than lack of access to healthcare. And this is a recently published paper that 1 in 10 patients are harmed by poor quality healthcare in high-income countries, while in low-income countries, 15% of all deaths could have been prevented if the quality of healthcare was rendered to the people. So that is something which is very important to make sure that we invest into quality as part of the universal coverage. So in Tanzania, there have been some achievement in terms of infrastructural development in attempt to actually achieve universal coverage. And as you can see from this line graph, there's a tremendous increase in the number of facilities being constructed. However, still we have close to 50% of villages in the country which do not have any public health facility. And that's to say that we need to continue investing, but also to consider the fact of quality to be part of the equation for us to be able to achieve the universal coverage. So this is some of the photos which were taken from different areas. There have been construction from the primary health care, secondary and tertiary level, and all these facilities have been equipped, and also there have been maintenance to the equipment which have been installed in these facilities. But looking into availability of healthcare workers, there is a variation in terms of availability. So you find that the national average ratio, meaning the physician per population ratio on midwives per population ratio, still Dar es Salaam is the leading region in terms of having high number of healthcare workers, and we have some other regions like Simiyu with less number of healthcare workers. So this should be one of the things that has to be considered while we are moving on the journey to achieving universal coverage, because we need equitable distribution of healthcare workers. There should be even a distribution of healthcare workers. Then looking some of the indicators in terms of access and coverage, there is a immunization, child immunization. Tanzania has been performing tremendously in terms of the vaccination and the immunization coverage. As I'm speaking to you now, the Penta 3, the coverage is at 94%, and that has increased from 75%, which was the case in the year 2016. So that is a massive achievement in terms of the immunization coverage. But looking into health facility deliveries, also there have been some notable progress. That in the year 2016 we had facility or institutional deliveries of 65%, but in the year 2022 we have arrived to 81%. This is a key indicator as far as universal coverage is concerned. However, we can see that there are some of the indicators which are not performing very well, including the first antenatal care visit before 12 weeks of gestation. We are not performing well. And this is one of the key indicators if we are to actually eliminate maternal mortalities in the country. So this is an area which needs more impetus, more investment, so that mothers can turn up to our healthcare facility during a very early stage of their pregnancies. And looking into the availability of health commodities, the government has done a tremendous job. There have been a gradual increase in terms of commodity availability at all levels, from dispensary to the health centers to the district level, as you can see from the graph to your left-hand side. That's why you can see that we moved from 61% in the year 2021-22 to 67% in the year 2022-23. Though we still have a work to do, because we need at least to have 80 as percentage moving forward. Then looking into the health system response. Health system response simply means the non-health aspect of care relating to environment and the way health services are provided. This is a very important indicator, because majority of times people will be very much concentrating with the clinical services which are provided to the patient, but the non-health aspect, the issue to do with the provider's attention to the client, the issue to do with the autonomy, basic amenities of the facilities, access to care, all these 7 domains must be there all the time for the people to enjoy the services rendered to them. Then that takes to the third component of our what we call the universal coverage. That we have the healthcare financing. Tanzania have endured number of healthcare financing reforms dated back in 1961, when we had the free healthcare services for all. Then in 1963, we had a structural adjusted program when we introduced the user fees. 1994, the health sector reform, which introduced the cost sharing policy. 1996, introduction of community health care fund as a pilot in Igunga district in Tabora, and that laid a foundation for the establishment of the improved community health care fund, which we are enjoying right now, and the National Health Insurance Fund in the year 2000. And in the year 2000, it's an important year as far as the health sector is concerned in Tanzania, when we also have the basket fund establishment. And in the year 2001, we had CHF and the NHIF Act, and the other important key milestone as far as the healthcare financing is concerned is the last year Universal Coverage Act being signed, the bill being signed into act. That's a massive, and the implementation of which is underway, we are enjoying. But this year, on 31st of January, we had integrated and coordinated community healthcare program launched by His Excellency, the Vice President of Tanzania, Dr. Isidore Mpango, in Dar es Salaam. And that is very important in terms of access to the healthcare. Looking into the sources of funds which we have, the insurance, the NHIF and CHF, both coverage is 14%. So that's to say that still 86% of Tanzanians, they use out-of-pocket payment approach to access services. And that is not something good. That's why we are very happy that last year in November, we had our bill being signed into act, because through that process, we are sure that everyone will be included, and we shall use the mandatory health insurance for all. Then we have the health sector basket fund, which 90% of its proportion goes to the primary health care financing. We have the government grants, development funds, council-owned sources, user fees, and also receipt in kind. So these are the financing options which we have in the country. But looking into the health basket fund, which started in the year 2000, it's a kind of a pooled financing mechanism to strengthen primary health care services. And 90% of healthcare basket fund is disbursed to the local government level, using the resource allocation formula. You know, with provision of resource or disbursement of funds, fairness is key. If you miss fairness, then you won't be able to address number of challenges, especially the health challenges at the lower level. Health Basket Fund has a combination of sector budget support and performance-based features, which are very important to enhance efficiency in service provision. And looking into the government spending on health, it's always that whenever there is higher government spending on health, is associated with better health coverage. And this is just to show you the scatter plot and how different countries has been are spending on health. You can see Tanzania is somewhere in the middle, and we are progressing very well. If you are to compare, as I showed you in my first slide, on the universal coverage index, we are somewhere there at the 43%. But some other countries like Algeria are performing very well, Botswana as well. But we need to carry on up with our momentum for us to be able to achieve universal coverage. Looking into what we have done in terms of community health care workers is one of the very important options for improving access to health care. You find that we have already launched, as I said, the Vice President was the guest of honor, and also we expect that we shall be enrolling more than 294,000 community health care workers to be deployed in all hamlets. We shall have 2 community health carers per hamlet, 1 male and 1 female. So the gender issue is taken care. And now, in terms of the key achievement, maternal mortality ratios, you can see that we have done some tremendous job in terms of reduction of maternal mortality, although we did stagnate for more than 10 years. In 1996 out to 2015, 2016. But it was with the recent survey which we saw that we have reduced maternal mortality by stone drop. Everyone is excited to learn that how come did you achieve that much? It's down to number of factors, including investment in the prevention part, investment into the primary health care facilities, equipment at all levels. Our diagnostic has also been improved tremendously over years. So this could be one of the reasons. So this is one of the indicators which we are on track to achieving by 2030. But still we need to keep the same momentum. Looking into the 3 indicators on neonatal mortality, infant mortality, and under 5 mortality, well, we are performing well. We have downward trend, but still we have to make sure that we invest more, because these are some of the indicators which we are not on track. But if we invest more, surely we shall be able to. So we invite different partners, because this cannot be invested by the government alone. We need different stakeholders to join government hands to address that one. So what are the challenges? The challenges which we have is quality of healthcare services. We still need to have different stakeholders joining government hands to invest in the quality of services, because we have been getting sporadic complaints from different parts of the country, people complaining of quality. But with the strategy which is in place, and also having approaches like Mama Samia doctors who are mentoring the lower facilities, we trust that that will help to improve the quality. The issue of human resource for health, here there are 2 things. There is number in terms of quantity, but also the quality. So this is an area also where we, the government invites different stakeholders to invest. The issue of task shifting, task sharing, and also using some new approaches like workload indicator for staffing need. The issue of poor leadership and governance at primary health care is another issue. We have some facilities which are not performing up to the expectations. We need investment in that one. Out of out-of-pocket payments, as I explained in my previous slides, that still we have 86% of people who are using out-of-pocket approach to access health services. But one of the huge challenge now is the rapid increase in the burden of non-communicable diseases. The expenditure has gone up, and everyone is worrying that if we do not reverse the trend, we do not invest into preventive services, promotion, then it will be very difficult to be able to handle it, and that will cost us a lot of monies in trying to address that challenge. Opportunities, we have strong policies and guidelines. Let us exploit that. We have integrated and coordinated a community healthcare workers program launched, and that will offer health promotion, prevention, basic curative services, nutrition, and social welfare services. So let us use this approach as well, because we shall have the facility-based, but at the same community-based. If you combine, then we shall improve the access to services. Then reforms, implementation. One of the notable is direct facility financing. The money being dispersed from the treasury direct to the facilities without going through anywhere. And those are some of the reforms which we should embrace, including the private vendor system. They have helped to revolutionize our healthcare system. Resource allocation formula, that should be the way to continue, because with that one, it can create fairness in the disbursement of funds. Innovation, we have innovation like M-Mama system, which is a homegrown. It has helped to improve actually access to referral means by the mothers who are in need, from the community to the facility, and the facility to the facility. So we need to continue monitoring those innovations, which helps us a lot. Then we have research and documentation of practices. The good thing now, universities, research institutions are trying to make sure that they support the research and documentation. So this is what we want going forward, because in the end we need evidence-based policies and evidence-based interventions. So this is one of the important slides that we should, all of us, go into system thinking. And I'm glad that one of the books which was published by a team of Tanzanians, including the member of faculty from University of Dodoma, it was published last year, and it tried to challenge the WHO's health system building blocks by also introducing some other determinants which has some bearing into our healthcare system, including the political determinants, the commercial determinants, the global initiatives, as well as the socio-economic determinants. And these must very much be considered at any point in time when we are making decisions. It has to be systemic. We should have system thinking, and that's quite very key. And these are important readings. These two books were written by a number of scholars from University of Dodoma and other universities in the country, policymakers and implementers. The first one to your left-hand side is the leadership and governance in primary healthcare, an exemplar for practice in resource-limited countries, but number of scenarios, number of examples are mainly from Tanzania. And the other one is primary healthcare in Tanzania through health system lens, a history of struggle for universal coverage. This is one of the very well-written book, and it's a documented history of healthcare industry in Tanzania since 1800. So one should try to get a copy. And these two copies are available in Amazon bookshop. You can bookstores, you can access them and read them to get to know the journey the Tanzanians have gotten to arrive to where we are in an attempt to achieve the universal coverage. The way forward, strengthening the delivery of people-centered quality services We should strengthen the delivery at the primary health care level, where majority of Tanzanians are opting or resort to whenever they are in need of health services. And then we should realize the efficiencies within the existing resources envelope, but with whatever amount of monies which we are getting, we should make sure that we use them optimally. We should promote strategic purchasing, promote evidence-based cost-effective intervention, but try to streamline implementation research alongside all new intervention. But we should invest in evidence-based policies and intervention. In conclusion, Tanzania universal coverage will be achieved by continuing investing into access, quality of services rendered to the people, and social protection. We are glad that the bill for universal health insurance was signed, and that is a good step forward in the journey towards achieving universal coverage. But this should go in tandem with making use of evidence-based policies, strategies, and interventions. I thank you.